Hello, everyone. My name is Gerard Krause. I'm with the Helmholtz Center for Infection Research, and I have the honor to chair this session today at the World Health Summit that will today, for the circumstances that we all know and for the reasons that we all know, take place only virtually. I see quite a number of participants are already joining in, which is great. Welcome, everyone. We have a quite interesting program and also very timely program today to present to you, focused actually on the COVID pandemic. The title is Digital COVID-19 Pandemic Response Management, SORMAS for COVID-19 Response Across the Globe. And I'm very, very happy and also very, very grateful that we have a number of presenters here from around the globe, from around the time segments, actually, the time zones. So some of you had to wake up now very early. So instead of having jet lag, you now have a Zoom lag. And thank you very much for still being able to join in. I would like to share the cover slide with you so that you can see the program, because we have slightly rearranged the order. This is the program that we have today. After me giving a short introductory presentation on what SORMAS is actually about, we will have a presentation from Lois Olajide. She is the coordinator of SORMAS in Nigeria, in which she will report on the experience in the SORMAS response, in the COVID response with SORMAS in Nigeria. Then we have from Ghana, Dr. Franklin, director of the Disease Surveillance Department at the Ghana Health Service. He will also describe the experience from Ghana. We have Olivier Lucy from France describing his experience in jump-starting, so to speak, SORMAS in France. We have Professor Dagmar Starke from the Academy of Public Health in Germany describing a special aspect, namely the training and promotion aspects of SORMAS in the case of Germany. We have Lauro Vives, who was instrumental in deploying SORMAS in Fiji in a record-breaking time in Fiji. And Dr. Karl Leitner from PATH Digital Square, who will describe the principles of global good practice with a special focus on SORMAS. So we have a wide variety of presentations from different countries, different settings, on one digital tool, which is SORMAS. And because it is all around this tool, I take the liberty to present what SORMAS is actually about, to put everyone on the same page so that the different presenters don't need to repeat and present redundant explanations. So I will try to, let me see if this works. The objective of SORMAS is to, as the name says, to have a surveillance, outbreak response management and analysis system all in one that includes early warning and analysis, response process management, laboratory integration, clinical management, mobile, offline, bidirectional management of data to be scalable and sustainable on the long run. And in order to do this, we need to take into account the different procedures, like detecting cases in the first place, in the community or in the hospital, even involving the community, the citizen, to commit to report cases, and also detecting cases as a screening measure, for example, at the point of entry. And SORMAS addresses all those activities for different interfaces. Once we have those signals, we need to investigate what those signals are about, to validate the reports, either by laboratory, but also by epidemiological investigation, to later then analyze and take decisions to then allow evidence-based control measures for the case management of the patients, but also for the contact tracing, which has become so important now in the fight of this particular pandemic. Now, keep in mind that this system was not invented for COVID. It was only now adapted for COVID. It has actually been invented based on the experience of the Ebola epidemic. Now, all those data from the different functions and different actors feed into the central system and then are being analyzed in a centralized dashboard and decentralized dashboard and then sent back as action orders or as information to the different people on the ground to work with that information. So you have seen many different users, those for detection, those for investigation, those for control and containment, and all of them have very special functions, and for each of them we have developed and programmed very user-specific interfaces. This then leads to very complex process models for each of the different activities. You can now here zoom in, for example, for the contact follow-up box, which will then open an even more complex interface and process model that contains all the different eventualities that are relevant for contact tracing. And this then guides the user through the process and helps the user to execute the work and to also maintain quality control. Until in the end, the user, the health officer, has contact with the patient and processes the data collected through this visit. This is for contact tracing, but SORMAS includes a number of process models for all kinds of other activities like preventive treatment, vector control measures, veterinary health activities, vaccination activities, environmental sanitation, depending on what disease needs what kind of procedure. So for contact follow-up, we have a number of diseases where this becomes relevant. Other diseases need preventive treatment. Vector control is yet relevant for other diseases. Veterinary health is relevant for rabies, for example, and guinea worm, which also contains contact follow-up. And vaccination, of course, also for those diseases that are vaccine preventable. Environmental sanitation is also relevant for some diseases. On the upper left corner, you see emerging disease X, which was a function that we had developed before the pandemic to be prepared for a pandemic and for an emerging disease for which we didn't know the name yet. But because we had this function established, we were able to deploy a COVID-specific module within very short time and to have a COVID-specific tool in SORMAS established in very few weeks, even before WHO had declared the outbreak in Wuhan to be an event of international concern. We also have a module for clinical management for those hospitals that don't have digital health records and digital medical records in place. SORMAS takes also that role. Now, all those information are then processed in the system and can then be displayed like this, where you see the red dots being cases and the green dots being contacts. And the links, the lines, the black lines describe the connections. And this helps analyzing and investigating and also interrupting transmission chains, because we now understand how the transmission occurs and we can investigate and prioritize our activities accordingly. This is real data coming from Nigeria. It's fully anonymized, so I'm allowed to share this with you. So as we had progressed, we have also developed different variations to implement SORMAS. We have SORMAS Common, which is a system where you have one central database and the different health departments get and feed the system directly to that central database. We also have another way, which is SORMAS Local, where each local health department has its own database fully separated from the other, which in some countries is necessary due to data protection services. So here we have virtual instances separated from one another. Even though they run on one server, they are running on separate Docker containers. To complement that and to make exchange between those local instances possible, we have SORMAS Exchange, which is an additional function that allows data exchange between those separated Docker containers, which is of course important if you want to share information and address the problem of transmission chains that will expand beyond the border of your local health department. We have also developed a concept that we call SORMAS Extra Layer, which is an additional feature to the SORMAS Exchange, which will then allow to have transmission chains, as I just described and demonstrated, also visible, even though you do not use a central database as in SORMAS Common. So this is basically the best of two worlds. You have fully isolated instances, but yet you have a way to share the information and to visualize the information across the instances by still keeping your personalized information on the local level. We also have SORMAS Mobile, which is very much used in the Southern Hemisphere, where local tools are necessary because the offices are not all connected to the internet. And we have a symptom diary, SORMAS Symptom Diary, which involves the contact person directly to enter information to SORMAS via his own or her own cell phone. So all those different modules can be used, and the country can choose which module to use. And altogether, it will bring additional advantages. We have the COVID-specific process models. We have a workflow and the team management. We have automated performance indicators and detection signals. It can be used as a mobile or a desktop version. Data security and confidentiality principles and measures are followed based on the EU norms. We have this mobile digital symptom diary that I just addressed and will explain in more details. Data can be accessed simultaneously without delay. You have the possibility across borders to share information, be it states within a country, be it counties within a state, or even across national countries. And it can all be synchronized with existing surveillance system, like for example, DHIS2. So here you see the German version of the symptom diary with a mobile phone that is being used by the contact persons. And it helps and reduces the workload for the health departments because they don't need to make the calls every day. The contact persons themselves will enter the information because the app reminds the contact persons, please tell us now what your symptoms are. And they will enter the information. It will be synchronized directly with a laptop, with a desktop version of the local health department, so that the local health department will have full control over the situation at every point in time. So SORMAS, before the pandemic started, SORMAS was already running in Ghana and in Nigeria, and we will hear the examples shortly. Now, as the pandemic unrolled, a number of countries in Europe and in the Pacific have added and have started implementing the system. And additional countries here in blue are now in the process of implementing the system, and some of them will be starting very soon. So we have a situation where, based on this emergency need, SORMAS is being used in increasing number of countries. With that, I would like to stop, but I would also like to thank all the participants who have been supporting, and all the institutions who have been supporting the development, the implementation, be it by complementing their scientific and IT knowledge, or by their advice and experience, or also by their financing. Thank you very much at this point. And now I would like to unshare my screen and give the opportunity to Lois from Nigeria, the country that was the first to develop and implement SORMAS. It was really also the country that initiated the idea of SORMAS. The whole idea was born in Nigeria, I must state at this point. And together with us here in Germany, we developed the system 4 years ago. And now it's being used in many other countries. So that's also the reason why I would like to give Lois the opportunity to present as a first speaker. Please.
Thank you very much, Gerald, and thank you once again for the opportunity to share Nigeria's experience in the use of SORMAS to contain the spread of COVID-19. Once again, my name is Lois Olajide from the Nigeria Center for Disease Control. So I'll be following this outline. So as a form of introduction, Nigeria recorded the index case on the 27th February 2020, after which a level 3 COVID-19 emergency operations center was activated, which is actually the highest level of EOC. And as of this morning, Nigeria has recorded 61,930 confirmed cases, out of which 57,000 have been discharged. We've recorded over 1,000 deaths with over 600,000 samples tested so far. And our case fatality ratio is 1.8%. So we have the distribution, the map on the right shows the distribution of confirmed cases across the states in Nigeria. So before the pandemic started, SORMAS had actually been deployed in 19 states of the country. However, due to the quality data we've been getting, Nigeria between January and September, SORMAS was actually deployed in all the states of the Federation and all the local government areas in the country. So this full and massive deployment actually entailed deployment training running concurrently in different states of the country, procurement of devices, insurance coverage for the devices that are being used, data support, as well as deployment of support officers across the states of the Federation. And the COVID-specific module was also deployed on SORMAS even before the first case of COVID-19 was recorded in Nigeria. After the first case of COVID-19 was reported, a point of entry risk assessment was done, which led to the monitoring of persons of interest. And so this monitoring, the POI monitoring, led to the prompt identification of cases as well as identification of contacts and follow-up. And all this information were actually reported and captured on SORMAS. And so this POI monitoring actually led to the development and review of strategies and guidelines, which has actually been helping us in the response to COVID-19. And so far, there have been 4 revisions of strategies on travels and on follow-up. The availability of real-time data and the detailed analysis of this real-time data actually enabled us to identify the cluster of cases and the epicenter of the epidemic, and also to identify risk factors for infection and for fatality. And this showed that the elderly and those with premorbid conditions were actually at a higher risk of infection, which is also in keeping with the global trend. And this also, the analysis of this real-time data also enabled us to identify that higher number of cases were being recorded in the metropolitan areas and lower number of cases and testing capacities in the rural areas. So this identification actually enabled us to inform, it actually informed the decisions across Nigeria in terms of risk communication activities, in terms of infection prevention control measures that are put in place. And before now, all SORMAS activities and sample collection were being coordinated at the center. And so this prevented those in the rural areas and the lower areas to have easy access to this sample collection site. However, due to the availability of the real-time data from SORMAS and its analysis, it led to surveillance activities being coordinated at these lower levels and also establishing sample collection centers in the rural areas, thereby decentralizing surveillance activities and sample collection in all these rural areas. The availability of this real-time data as well as its analysis also enabled us to carry out a detailed epidemiological analysis. And this detailed epidemiological analysis revealed that 20% of all our local government areas were responsible for 70% of the cases being reported in Nigeria. And so this led to the development of the hotspot strategy, which entails enhanced surveillance activities and contact tracing in all these local government areas. It also led to the identification of states with high burden of the disease, as well as having a low contact to case ratio. And so this led to the recruitment, training, and deployment of community healthcare workers in these high burden states who are there for active case search and contact tracing. We also identified that a number of healthcare worker infections were being recorded in these high burden states, and this led to having targeted IPC training, which is ongoing in the states. We also have this case investigation from CIF SORMAS app, which is being used by the public, such that they can actually fill this case investigation form before getting to the sample collection site, and this reduces the time spent at the sample collection site. Also, because of the, we also recorded a delay in turnaround time for result release. And so this delay led to the automatic release of negative results from the SORMAS platform via SMS. And so this allowed us time to focus on the positive cases, thereby ensuring prompt isolation of such cases. We also have this automatic transfer of contact information from the SORMAS platform to the NCDC Connect Center, which for automated calls to such contacts. And this also enables prompt testing and isolation of such contacts once they become symptomatic. So we're not without our challenges. And one of such challenges, when Gerard was discussing, he mentioned the issue of the availability of the mobile app, which is being used in areas with poor internet connectivity. However, what this does is that in these areas with poor internet connectivity, it affects synchronization of the data that is obtained from the field. However, there is the development of this new technology, which is called the low bandwidth database synchronization. And so this one allows allows complex database synchronization, even in settings where the mobile connection is not so strong. And this is likely going to be available early next year. We also have a number of our states depending solely on the national for procurement of devices that are being used on the field in terms of procurement of devices, insurance coverage for these devices, data support, as well as support officers in these states. So these are some of the challenges that we have in the country. In conclusion, SORMAS, as I said, has really been an important system for routine surveillance, and it has really been instrumental in our war against COVID-19 epidemic in Nigeria. And because of the robust design that is available on SORMAS, which affords the interaction of the real-time data between all the different pillars of the outbreak response, ranging from case investigation and contact tracing, sample testing, case management, it has really been pivotal in our decision-making and policy formulation as we continue pushing to curb the COVID-19 pandemic in Nigeria. And the sustainable use of SORMAS at all levels will continue to make a remarkable difference in our fight, not only against COVID-19, but against all infectious diseases. Thank you very much.
Wonderful. Thank you very much, Lois. Unfortunately, you cannot hear us clapping our hands, but very good and very brief, very complete and comprehensive presentation. I'm sure there will be comments and questions at the end. We will have the question and answer session at the very end of the full session, because some of the questions may be relevant for more than one speaker. So now it's my honor to give the microphone to Dr. Franklin Aziedo-Bikoyi, who is the director of the surveillance department and the Ghana Health Service in Accra, in Ghana. In Ghana, the situation was such that we were still at the stage of piloting SORMAS, actually, when the pandemic unrolled. And therefore, the interesting thing is to hear how you change from a pilot stage to a full implementation setup in the midst of a pandemic. Dr. Franklin, the floor is yours. We cannot hear you yet, in case you are speaking.
Yeah, so good morning. Yes, I'm Franklin from Ghana. Let me say that COVID has actually brought a lot of benefits to Ghanaians with respect to SORMAS implementation. And my slide acknowledges contributions from the Ghana government, GIZ, AZI, and then GCNet. So my presentation looks at how SORMAS was adopted in the country, how were we implementing SORMAS as a pilot, and then in the midst of the outbreak, we had to scale up. What were some of the success stories that we had as at now? the challenges we have, and then the recommendations going forward. So Ghana actually followed suit from Nigeria, and we actually adopted the model from Nigeria. But we went ahead to modify the Nigerian model into the Ghanaian context. So we actually added anthrax and rabies as priority diseases to the package of diseases for surveillance. And then we also changed the nomenclature from the Nigerian context into the Ghanaian situation. Let me say that before the pandemic started, we also went ahead to adopt the COVID-19 model. So we had a package of SORMAS before the outbreak. But let me say that Ghana piloted SORMAS in two distinct regions. Ghana have 16 regions, but we did a pilot in 2 regions, that is Greater Accra, which was specific for cholera, and then Upper West region, which was specific for meningitis. So these are the areas that we did the pilot. The pilot actually started in November 2019, and the 2 regions had 40 districts. There were 29 in Greater Accra, which is the capital, and 11 in Upper West region. The Ghana implementation of SORMAS is actually a private-public partnership. It involves the Ghana Health Service, which is for the government side, AZI, and then GCNet. And all of these players are crucial for the success of SORMAS in the country. So a number of activities took place in Ghana as part of the pilot. It involved acquiring tablets. So these are pictures that shows you what went around, and then the training of supervisors, the training of users. So a lot of people in the 2 regions were actually trained, and the logistics were made available by our partners. Ghana reported the first 2 cases on the 12th of March, and somehow we were lucky. The first 2 cases were reported in Accra, which is a pilot region for SORMAS. So we immediately zoomed in about implementing SORMAS. But then the next case, that's the 3rd case, occurred in a region that was not part of the pilot. So immediately we had to mobilize ourselves to see how we can get SORMAS on board. And then the vice president thought it's wise that we need to actually get SORMAS to scale out the whole country. So that was the direction. Initially, it was 2 regions part of SORMAS, but then the idea was to make sure that SORMAS went across the whole country, involving the 16 regions. So it was about data entry. It's about getting all the labs to be part. So we moved on from just 2 to 14, and then 14 teams were actually formed to be addressed to each of the regions. Each team had 4 national officers, and then they had a number of tablets that were supposed to go along. What they did was that each region assembled the district teams, and the teams were actually put together in a location, and they were taken through key areas of how to report cases, how to document and send samples to a lab, how to add contacts to cases, how to do follow-up of contacts, and then how to migrate contacts once they become positive. So these were the key things that were done mainly to address case reporting. Then we decided to use what we call the barcodes. The idea is, how easy is it for us to be able to buy the cases for us to do contact tracing and follow-up? So the Ministry of Communication helped us to develop these barcodes. So the barcodes are actually added to the sample for ease of identification. And what happens is that these barcodes are actually attached to the details of the samples, and then they are dispatched to the laboratories. So when you have a suspected case of COVID, and then you take the sample. Normally we were doing either sputum or we were doing nasopharyngeal swab. So when you take those samples and you put them in a container, then you now have these barcodes that are now attached to the sample containers, and then it's sent to the lab. Also, as you fill the data in SORMAS, then you scan the information on the barcode to be part of the PID data of a case, and then it's now sent to the lab. And at the lab, the labs will scan the barcodes so that they get all the detailed information of all the cases. So let me say that initially Ghana had only 2 labs, basically in Accra and Kumasi. But then, as I speak now, we have 16 labs, all in trying to address SORMAS, so address COVID. So these labs, one requirement to be accredited as a SORMAS or as a COVID testing lab is that you need to train on SORMAS. So we make sure that you are actually well trained, your staff, and then we give you a number of logistics, including laptops and then tablets. And then you are certified to be part of the testing sites in the country. We also decided to use the case management model. So here, the symptomatic confirmed cases are monitored. And we, the surveillance team, work together with the case management team to make sure that we actually update this model. Our technical providers, that's GCNet and AZI, have been very instrumental in upgrading the SORMAS model as we progress. So as I speak, we are still working on making a final update of the case management model, but it is good for use and we are using it. So the SORMAS in Ghana has actually been upgraded from the original one. So we have the case investigation model, we have the laboratory model that includes the use of the barcode, and then we have the case management model, which is used to manage cases of COVID. What has been the success stories in the country? SORMAS has actually broadened the scope of surveillance in the country. So now we can talk about real-time data flow to all levels. There's also easy laboratory sample documentation and management. And I'll say that this is mainly due to the fact that the barcode has been an added advantage. Then we're able to do data monitoring and supervision. And let me say that we are doing this very remotely from the national and regional levels. There's also a high level of involvement in the development of SORMAS. Initially, let me say it was AZI and GCNet that were the key people who were promoting the use of SORMAS. But for now, the presidency and then the Minister of Health are all keen in the success of SORMAS. There were initial challenges about how do we get SORMAS and DHIS2 integrated. But our Director General has actually led the direction. So as I speak now, there's a big direction about integrating SORMAS and DHIS2. So coming Tuesday, there's a big workshop about how to integrate this SORMAS and DHIS2 and GCNet, Ghana Health Service, and then the DHIS2 are going to work to make sure that we have fruitful integration of SORMAS and DHIS2. There's also a high active user of SORMAS in the country. The next slide gives an idea of how SORMAS usage has moved from a very low figure of let's say about 100 in January to now over 5,000 to over 3,500 as of September. So virtually all the 16 regions and then the 260 districts are actually using SORMAS as I speak now. There are a few challenges, I think, which is not unique to Ghana. I think it pertains also to Nigeria. The tablets for use are limited. There has been a lot of effort from central government and AZI and GIZ to support us with tablets, but I think that there's also an obvious challenge about the adequacy of it. Though Ghana has a high internet penetration, there are still challenges about access to it, so that affects effectiveness of implementation. And then to get SORMAS fully running in the lab, they need to have laptops, and we don't have adequate numbers in the laboratories and also for the use by supervisors. There are a few challenges with respect to the actual usage of SORMAS. I'll tell you that there are some regions that don't have the maximum entry into SORMAS, but collectively, I think that almost about 90% of our data is actually being entered into SORMAS. So going forward, we are still asking the total management involvement. There's a bigger direction from the presidency, but I think that there are some few challenges with respect to the districts which we hope that it will improve so that we get the full benefits of SORMAS. Then the data entry, as I said, we are around about 88 to 90%. We're hoping that the entry will be 100%. They will have the full benefits of SORMAS. Then to address the challenges with availability of devices, we are collaborating with other key partners and companies so that we get the adequate devices, including tablets, and then laptops to support the response. So let me end by acknowledging the Ministry of Health and Ghana Health Service, GCNet, AZI, and GIZ. Thank you very much.
Wonderful. Thank you very much from my side also. Very interesting, also very impressive that Nigeria and now also Ghana were able to roll out SORMAS under those difficult conditions of a full outbreak response situation to the complete country in very, very short time. So I think we will have to ask you how you did this, because some of us in other countries in Europe have difficulties getting this implemented. So speaking of Europe, actually, I would now like to change the continent and give the word to Olivier Lucy. Olivier Lucy is Directeur Adjoint de Santé in a region, a specific region in France. And I remember very well when he contacted us and was interested in using SORMAS in France. And we were contacted by many, many countries. But the special situation in France is that basically, since SORMAS is open source, the French just took all the codes that we had displayed and developed the whole work themselves with only limited support from our side. So that was also very interesting to see, and I thought it would be a good idea to also hear how the French colleagues did this and what challenges they encountered in doing so, and also what recommendations we can maybe take home to increase the open source philosophy of SORMAS. So Olivier, please go ahead.
Okay, I will up this one. Okay, do you see my screen? Okay. So first of all, please excuse my English skill because it's far away from me to practice. So maybe I will find some difficulties to speak in English, but I will try to do my best. SORMAS was a needed response for COVID-19 because we operate a regional health information system in my structure, and we don't have any technical and business response to this new problem for our kind of countries. So we were really happy to find it. And as Professor Krause said just before, we were really active to deploy SORMAS as a quick response of the COVID-19 pandemic. To give you an idea of what represents our region, you have a map here, and we are quite as big as Switzerland, but with less people, less livers in this region. But for the territories, we are quite the same size as Switzerland. It's about 3 million of people, just a little less. We are a new public EL structure, but we generate from 2 former EL's cooperative groups, and we have more than 15 years of experience in regional health information system management. And I am the deputy director, and my specialty, I am just a simple technician, so I am just an engineer. And I am also chief financial officer, but it is not the subject here. To give you an idea, from these 15 years of experience, we have a big health information systems. And you can find it. I think that we will share the PowerPoints files later, and you can find all what we do in our platform. And just for SORMAS, what we have done one production environment, of course, and we have 5 other environments: tests, devs, trainings, and other needs, because we have also one for integration. 7 employees are directly involved in SORMAS project in my structure, and we have signed a partnership with a private company, which is Olajide, and they provide 3 seniors developers. Till the beginning of our involvement in SORMAS, we have committed 10 major contributions, more than 10 major contributions to the project, and 15 are in the validation process till now. We have done a complex process for automatic data integration. As you can see on this file, we have 2 big files that arrive twice a day and give us all the information about contact and cases. And CDEP is for labs results, and Contact COVID, this is a national health insurance system that collects the data from the proximity clinicians of patients. So we merge the data files. I put you one module which is called EMPI, because we use in our region one EMPI, which is to identify with security patient in our different systems. So we do a check with the regional EMPI. After that, we do a check with SORMAS because there is an existing database. So we must check if in the files we don't have double or other kind of bad data. And we provide a new file that is included in SORMAS, and the team can use it. So it's refreshed twice a day. I will pass on this very quickly, but as you can see, the second wave is here. So it's easy to see it on the graphs. So we are now in the same situation than in March, finally. And we have this time SORMAS to help us to provide the follow-up process for the health team, the public health team. This was for case just before, and this is for contacts. Now for case, I just come back from the slide before. For case, we don't call them anymore by phone, as you can see on the graph, the second one, because we use another tool. Every people who are identified as a case in SORMAS are now followed by a telehealth system by clinicians. So we call just contacts anymore, because we don't have enough time to do all, in fact. The French deployment, I will speak. Odile Jamet is in charge of the national project. We have 2 regions, as you can see, the 2 in the different colors. This is Bourgogne-Franche-Comté, it's my region, but you have also the orange one, which is Auvergne-Rhône-Alpes, which is a big region. We have local instance of SORMAS, and we manage it as not like the rest of the country, but all the rows region you see are managing in one only inter-regional instance of SORMAS. So to give you some numbers, some details, today we cover with SORMAS around 40 million of people in France. As you can see, Auvergne-Rhône-Alpes is a big region, so it's around 8 million. And the inter-regional instance is around 30 million people, and we manage around 3 million people. So now we can see that SORMAS is able to be wide deployed for a country like us. What we find really nice in SORMAS, okay, so at the beginning of the first COVID-19 epidemic wave, we don't have any follow-up solution in our health information system. So SORMAS was already operational and tested in this type of lethal epidemic situation. It was a new situation for countries like us, so we were a little bit in demand for this kind of tools that we don't have in our health information system. What we appreciate also is the international nature of the project that give us the best possibilities for a worldwide collaboration, and it keeps also the possibility to give to make strategic choice like forking or anything else. So for us, it was also a condition to enter in this project. It was a real open project. So it was not like a prison with a proprietary project. So we were very enjoyed to come in this project. SORMAS also, as a technician, is modern in his architecture. So it's based on open source middleware that we were used to manage. So it was for us easy to come in. Last point is the excellent skills of HDDI business and technical teams. So they help us really quickly, and they were really reactive at the beginning of the project for France. So it was really nice for us to have such a help. And the real willingness of HDDI teams, and I would like to give many thanks to Professor Krauser and his teams to welcome us and to give us a real active place in the project. It was really nice that it was an open team, and we can manage with them a real collaboration. What kind of difficulties we have today? The solution was already operational, but France, as you know, has its own complex health information system. And sometimes it's really hard to find a route that meets specific needs for France and does not hamper other needs of the other country. And as you say, you must validate the issue that you propose with the HDDI team. And as you know, in France, we really like to think that we don't have the best idea of the world. So it was sometimes a little difficult for us to accept, but HDDI team do a real good job to be able to listen our needs and to fit the more specific needs we have and the more generic for other countries. So I hope that the issues we develop is useful for a lot of countries. We have also some problem of performance, but it was not especially a problem of SORMAS, but sometimes with the French implementation. So sometimes the lack of performance of the user experience was a little bit tricky because people want to return to Excel files, but we succeed in convincing them that SORMAS is a good tool to do it. And also because we have, if you remember one of my previous slides, we need to urbanize SORMAS in the rest of the health information system. And for that point, we need to do jobs that we will provide soon, I think, to integrate SORMAS in the rest of the other tools. We manage around 30 different solutions, e-health solution on our platform. So now SORMAS need to come back in the same condition of urbanization like the other application. It will be done, I think, before the end of this year. Okay. I hope I was not too long. Thank you for your attention. And sorry for my English skill.
Merci beaucoup. Thank you very much, Olivier, Lucie. Very, very interesting. Also for me, some new insights that I didn't know before. And a great other example how contributions are being provided from different countries into this system, depending on the country-specific needs. We will certainly come back to that during our discussion section. As I'm talking about the discussion section, please feel free to already type in some questions or comments in the F&A functionality of this Zoom thing. This will then facilitate to sort out the questions and maybe address them in a better organized way as we finish our presentations. Thank you very much, Olivier. Now we will stay a little more in Europe to the neighboring country, Germany. There's another European country also using SORMAS at a large scale, which is Switzerland. Unfortunately, I was not able to put all the country, for each country, a speaker to this program. It would have been too much. So I had to make a choice, and I asked Dagmar Starke from the Academy of Public Health in Germany to describe her view and her perspective from the SORMAS use and deployment in Germany. Please, Dagmar, go ahead.
Good morning, hello, and bonjour to everybody. It's really a pity that we cannot meet in person, but I'm happy that I'm able to present some of my views to SORMAS and in context of implementing a new e-health tool in German local public health services. The Academy of Public Health Services is an institution which is financed by 11 states of Germany, and our main task is to educate, to give trainings to all workers in the public health services, never mention whether it's the national public health service, the state or federal public health service, or the local public health services. Before I go into detail, I would like shortly to present some information about our project, SORMAS at DEMIS, which is funded by the Federal Ministry of Health, starting in July and going ahead until 2022. And the title is Development, Implementation and Evaluation of SORMAS at DEMIS at an Integrated and Networked Case and Person Management for COVID-19 for the public health service in Germany. And the aim is an integration of existing systems and systems in preparation, like SORMAS, like symptom diary, like SURFnet and DEMIS. And of course, our motivation is that the pandemic is a huge challenge for the public health services. And we do think that an integrated and network case and contact person management can be an important part in relieving the burden of public health on the public health services. And it's amazing that all of you mentioned the same problems. We do have different e-health tools in the local public health services implemented. We do have favor in the public health services for Excel tables as a way to manage cases and contact tracing. But finally, a lot of the public health services mentioned that it's not such a good idea to use this one. So actually, since March, we are cooperating with HZI in terms of SORMAS training and support for public health services. The aim is supporting the local public health service by implementing and applying SORMAS. So what we do offer to public health services is user training and special training for administrators via conference call and simultaneous use of the web application. That means remote opportunity to learn something about SORMAS and learn using SORMAS while initially applying it. Oops, wasn't the plan. And we do offer a hotline and ticket system, and that includes expert consultation and personally on the phone. We offer web seminars and a regular exchange of experiences via video conference system. We do have training video. We do have a test version with fictive data so that local public health authorities may try for the first time how SORMAS might work. We offer web-based user forum and news groups. We have a series of podcasts, and some of them do concern SORMAS. And of course, we have information material, user manuals for the public health services. And let me shortly say thank you to the colleagues in HZI and my own colleagues who are partly participating in this session for their huge engagement and their really big motivation to implement SORMAS in the public health authorities. I would like to introduce to you what are the different ways of contact between the public health authorities and us, or all the colleagues who are involved. That means from the initial contact to SORMAS training, we have different opportunities. So in the beginning, there's the request or interest from public health authorities, either via SORMAS support that we do offer, or via the Academy of Public Health Services, or a direct contact to Netzlink, which is the firm who is hosting the local service. So from the initial contact, the public health authorities get a package with info materials so that they can learn more about what the SORMAS is about, and they can learn more of the contract they have to sign if they are not willing to use the possibility to set up an own local server, but to use the opportunity that Netzlink is hosting the server. And all these different ways went into a ticket system, the hotline, and afterwards we do establish a first contact with public health services and arrange training dates. Every public health service receives at least 2 trainings, as I mentioned earlier, training via phone and web application, so that they can learn to use SORMAS while on the training. The training is remote. And the other possibility is also to get the info material directly and to sign the contract, and afterwards to get the training from us in cooperation with HZI. During all the time, we give support via hotline and ticket system, and with all the other offers we have to support the public health authorities. There are many ongoing demands and uptake. Right now, hotline and ticket system are daily available, of course, and they are highly frequented. Either they are public health services who want to get into contact with SORMAS, or they have questions about new releases or any other problems that might occur. Then we have, of course, training of the local public health authorities. As I said, at least 2 training sessions for each public health service via conference call and web application, and at least 1 special training for administrators who are relevant for user roles. Then we have newly implemented training on demand, currently really highly frequented due to the second wave, as luckily some of the public health authorities get new co-workers, and they really need a quick response, so that we try to offer them a training within 24 to 48 hours. Then we offer an exchange of experiences, and about 80% of SORMAS users do participate on a regular basis. Currently, we meet every 14 days, but this may change depending on the development of the pandemic. We have personal consulting, and due to our task giving trainings to public health authorities, we have really close personal contacts because the public health service in Germany is a small family. We do have not so many people working in this in the local public health services, which is a big problem right now, and which makes it really difficult to deal with the pandemic. And so people from the public health or colleagues from the public health authorities use the private contacts or personal contacts to get personal consultation in special situations. And finally, we do prepare and update the training material, what is necessary on a regular basis, because we do have updates every 21 days. We have a 3-week sprint and release. So we have a really quick response on the developers team to meet all the wishes and needs of the public health authorities. And this makes it really interesting for public health services to use SORMAS, because during the last 6 months, SORMAS has developed and changed a lot, because we are trying to meet the needs the public health services are formulating. And some aspects that may influence decision makers to implement SORMAS are, of course, the Docker container technology. They are informed about this earlier. That means, on one hand, public health services do not have to take care of the technological implementation of the system, and Docker container technology provides a high data security, and processes do have are separate on the different container solutions. We do have a data security according GDPR, and we have currently have had a penetration test, and currently we have a data security check on the national level to be sure that everything went fine. And of course, another point that is really important to me, at least, SORMAS is an open source solution, and all codes are available on GitHub, as you said earlier, all of you. And what's really important about this is because currently there are so many different firms, developers, whoever, who wants to sell a new instrument to the public health services, because of course it's clear that the local public health services do need a good solution, a good e-health tool to deal the pandemic. But actually, I think still think that SORMAS is the best one, not only because of already existing experiences from Nigeria and all of you who are involved right now, but also because SORMAS is really developing in a very fast way, so that the needs of the public health authorities are met. And to be prospective, thinking about SORMAS to SORMAS and the possibility to exchange cases or contact information between two public health authorities using SORMAS will really, really add to relieve the burden of the public health authorities. Okay, I would like to thank you all for listening, and I'm ready for your questions.
Thank you very much, Dagmar. Thank you. So now we have heard two presentations from Europe, and we will now move to the Pacific, at least as far as the report is concerned. Lau is actually now in Canada, I believe. So special thanks to him, and also the next speaker, Karl Leitner, for waking up at 4 in the morning to make participation possible here. Please, Lau, go ahead.
Yes. Hi, good morning. I'm just going to see if I can actually just share my slides here. Right. Okay. So I do apologize. It is actually 4 o'clock in the morning here, so I may not necessarily be all that coherent, but I will certainly try to do my best. So yeah, thank you very much. And just a little bit of background about myself. I work as the Director of International Development, and I'm also a senior consultant for a company called Jevity. And my background is originally from the Pacific, and I've done a lot of work in Fiji and in the Pacific. And one of the things that they've done is they've actually asked me to be in the Pacific, primarily to basically help contain this pandemic, given the fact that the Pacific is one of the most vulnerable populations against COVID-19, and I can explain a little bit more later on. So in this presentation, I just want to focus on a couple of things, talk about the background, give you some context, why Fiji was very strategic and crucial to the position in the Pacific, and then go into the SORMAS implementation. And most of all, I wanted to talk about some of the things that we've learned about this whole exercise starting last March. So a little bit of background, okay? So back in February 2020, the World Health Organization identified the Pacific to be one of the most highly vulnerable regions due to comorbidities, inadequate medical equipment, and the vast geographic distances of all these islands. So we know that there's a lot of challenges there, especially if the pandemic has hit. The one thing that everybody in the world should understand, is that the Pacific countries, particularly Fiji, were one of the earliest ones to take this pandemic very seriously, and they took proactive steps to curb the pandemic. So as early as February, we already had containment measures, prevention measures actually at the port of entry, doing temperature scans, checking the travel health documents of incoming passengers, both at the airport and at the ports, because Fiji is a very big, there's a lot of cruise ships that go through. So today, we are very happy to report that the Pacific region is actually the least affected regions in the world today. It is actually one of the safest regions in the world today. Since the first case that was registered in Fiji back on March 19th, Fiji had only 33 cases, two casualties, but all of that actually were mostly importation of the viruses during the quarantine flights or the repatriation flights. So if you're looking for a safe place to be, please come to the Pacific, because it is actually one of the safest places in the world. So to just give you some context, okay? So why Fiji? Well, we realized that in order for us to basically put a ring around the Pacific region, it was really important for us to basically focus on Fiji, because it is a gateway from, to the Pacific, from Asia, from Europe, from Africa and North America, if you come to think about it. And we realized that if we can basically, keep Fiji safe, we can keep the rest of the Pacific safe by delaying the importation of the virus. And by delaying that importation of the virus, it actually bought the whole Pacific some time. Just imagine the Pacific compared to Europe or even Africa. The infrastructure is just not there. We just don't have the population or the army of IT people that can actually work on these things. So we really did our best to focus on pre-containment measures, but realize that we actually need something like a tool in order to be able to help keep the Fiji and Pacific safe. So again, the heads of health in the Pacific have recognized Fiji's critical role in keeping the rest of the Pacific safe. So let's talk about the SORMAS implementation for a little bit here, okay? And I'll do my slides a little differently. I want to give you a timeline, because March 2020 is a month that I don't think a lot of us will ever forget, including myself. It was not a time where we had a lot of sleep, that's for sure. But given the fact that Fiji, the time zone differences between Germany and Fiji, it was actually quite a challenge, not just for us, but clearly, it was also a challenge for our partners with HZI, okay? So I'll just give you some idea, so to give you a little bit of background and context. So, before, like I said earlier, in February, the Ministry of Health in Fiji took this virus very, very seriously, while the rest of the world was still unsure on how to deal with this. Okay, but on March the 4th, the Permanent Secretary of Health and Medical Services essentially gave us the marching orders, to acquire an active surveillance and an outbreak management system. That system, we never had anything like that in Fiji. The public health surveillance system that we have is mostly event-based or indicator-based. It wasn't active surveillance at all. And certainly we had no contact tracing system. So that was on March the 4th, okay? So everybody was on the same page that we needed to do something very quick. And then between March the 5th and March the 16th, okay, we did not know exactly where we would get this system, but we knew that we needed to immediately define the requirements of what we're looking for. And in that period as well, we looked at doing a market scan, and surprise, there was nothing to be found actually. If you were to Google COVID-19, contact tracing and surveillance, your answer set when it comes to finding a potential solution was very, very limited. But we kept looking, and SORMAS was actually one of the few solutions that were out there. But there were at that time also quite a few companies that are repurposing some of their tools to become COVID-19. Some developed something, but it's never been proven. So what we've done, okay, was that we've actually shortlisted a bunch of vendors between March the 18th and March the 13th. And of course, SORMAS was shortlisted as well. But while we were doing that, we were also developing the requirements, because that's really key, And so what's happened was that on March the 14th, we're working with the Fiji CDC, and the decision was to essentially go with SORMAS on March the 14th. So you can just imagine, it only took 10 days for us to basically select, a trusted partner. On March the 15th to the 24th, all we did was develop the test strategy, the test cases, the test scripts. And that's all we could really do, At the end of the day, we were in the hands of our partner, which is HZI, but what we can control is essentially to develop the test cases and the test scripts. So that's all we've done, that's as a matter of fact. And, I don't know if some of you have been to Fiji, but in Fiji, it's a beautiful country, beautiful people, very relaxed atmosphere. You've probably heard of the term Fiji time, which means to say there is no time. Well, in this case, it's a complete opposite thing. We had no time. We needed to get these things done, and pretty much worked 24 hours a day with the support of our partners in HZI, who's also busy doing other things in Africa and in Europe. So that's all we've done. And between March the 18th to the 23rd, we did a little things differently in Fiji, because in Fiji, there's a policy that does not allow to store patient data outside of the country. So we actually have to request SORMAS, or the HZI team, to implement the data component of the SORMAS implementation on premise. And because no one can fly and everything had to be done remotely, it was really quite a challenge, And I think what really got us through this is the perseverance of the team, both the Germans and the Fijians, to basically make this thing work. So it took us roughly about 5 days to implement both a test system and a production system. And again, it was quite something to see, to be honest, because everybody was pretty much running on adrenaline, if I can put it that way, because we had no idea what the pandemic was going to happen, how the pandemic was going to affect Fiji and the rest of the Pacific. But like I said, unlike Europe, the healthcare facilities, it wasn't really prepared. You know, in the country, we've roughly only had 10 ventilators for a population of about 1 million people. So we knew what we had to contend with. So we were very much in a hurry. And then on March the 19th, Fiji registered its first case. So we knew we were running out of time. You know, I mean, now we can say everything was fine, everything was good, but at that time we had no idea. We absolutely had no idea. So on March the 19th, the first COVID case was registered. And between March the 24th to the 30th, all we've done was basically continual testing, testing SORMAS now that it's actually in the test region. And all we did was test and do the hardware setup. Now, the hardware setup was quite interesting because we knew we needed tablets. There's no doubt. Fiji being a country that that relies on shipment of goods across the world, we actually had to try and get all the laptops in Fiji. Vodafone, which was essentially our partner in Fiji, could only give us about 50 tablets, and eventually kept looking and looking, and we managed to collect over 100 tablets, borrowed laptops from other government sectors. And the one thing that I have to honestly give credit to Fiji is that, they realized that this was not only a health emergency, but it was also a national emergency. So all the government sectors basically pitched in, contributed whatever they can provide in terms of hardware, software, and people. As a matter of fact, the configuration of the tablets, it took maybe about 25 IT people across government, to basically try and get the tablets and laptops configured. So from March 28th onwards, and the training still continues today, by the way, training was conducted. And given the fact that there were lockdowns already, given that the first COVID-19 case was actually registered, it was very, very difficult to actually conduct the training. So a lot of that had to be done virtually as well. So at the end of the day, we actually went live March the 31st. So in less than 1 month from the time that we got the direction from the Minister of Health and the Permanent Secretary, to March the 31st, we actually got the system in place in less than 3 weeks. As a matter of fact, if we even look at it, when we made the decision to go with SORMAS, it took us roughly about 2 weeks, and we could never have done that if it wasn't basically, having a trusted partnership with HZI. Fiji is the 165th country, to actually register its first case, but one of the first countries to implement an active surveillance and contact tracing system. And of course, that was SORMAS, who we've actually decided to partner with. So the implementation profile of SORMAS.
Please, we need to hurry up a little bit because they will cut us off if we don't stop, and we still have the presentation from Carl that we also need to hear.
Right, okay, sorry about that. Yes. So I'm gonna skip through this, okay? So what are the lessons learned? So we needed to act now and avoid the analysis paralysis. What's really important is for us is to develop the requirements, but to establish the requirements good enough to establish the minimum viable product. We've also had to engage pretty much all the stakeholders, because at the end of the day, this is not an IT decision. This is actually, a business decision that needs to be made. And although HZI have already provided us with some test cases, we went beyond the test cases they provided us, and we needed to develop our own test cases. The fifth lesson learned was that we needed to be very clear on the roles and responsibilities and be flexible to accommodate the limitations of SORMAS at that time, in which at that time was still evolving quite rapidly. And so it was not a perfect system, but it was something that we can live with. Sixth lesson learned is that I mentioned earlier that the patient data is actually hosted on premise. If possible, implement the whole SORMAS on the cloud for rapid deployment, because breaking SORMAS that way took a little bit of time. And of course, number 7, it's important that when you basically go out in the field that there's adequate IT support in case the tablet's not working. Lesson alert number 8, never stop testing. You know, that was something that we took on very seriously. And of course, number 9, never stop training. Today, we are continually training. The other lesson that we've learned is that you do not necessarily have to upgrade to the latest release. There were some, you know, we felt that we were at a release that was stable, and don't feel pressure to always upgrade to the latest release. Upgrade when you need it. Lesson number 11, keep the modification to the bare minimum to avoid further delays and to ensure that the code remain unchanged. In Fiji, although, you know, open source was not something that was actually in the architecture or preferred, because we just knew that we didn't have people that can actually support the code. So part of the deal that we had with H.I was that we would acquire software, the SORMAS software, but we also need to basically keep the, you know, we would get H.I to maintain the code for us. Lesson number 12, you know, it was really important to have a very disciplined approach to issues and defect tracking. We were monitoring that very, very closely. Number 13, I think this is really important. You know, the technology is important, but more important is that you have a vendor you can work with, right? That is really important. And lastly, number 4, there is no replacement for good project management. We recognize that for every day you lose, you can never, ever gain it back. So that pretty much it is in a nutshell. Thank you very much, and I hope I didn't take too long.
Thank you, Lauro. Thank you very much. What a pity that collaboration in these days is only virtual. And so now I would like to, without further ado, like to invite Karl Leitner, who will give another perspective, not so much from a specific country, but more from a helicopter view of global goods and digital tools and how that plays together. And also maybe we get some advice how we can establish a good open source strategy for the future. Please, Karl, go ahead.
Thank you all for the opportunity to participate in this, the World Health Summit. My name is Karl Leitner. I'm the Technical Director for Digital Square, and I just wanted to talk about the role of SORMAS as a global good, how it was used, and as well as some future thinking towards interoperability. Looking what are global goods, it was recognized in the global digital health investments in digital health tools that there was a lot of fragmentation of investments and the need to consolidate those investments into interoperable global health tools that can be used in many countries and at scale. One of the questions we often get is, what are global goods? There are sort of 3 types of global goods that we like to consider: software, services, and content. So software global good would be a free open source tool that's used to manage, analyze, or transmit health-related data. It's gotten proven utility in several settings. Services is it's a tool that's not necessarily free or open source, but freely accessible and adheres to strong open data principles. And content global goods are those global goods that are supporting digital health implementations, whether it's a standard, a resource, a toolkit, or other implementation support materials. Digital Square invests in global goods, and you can see a number of the tools that we've invested in over the years, and this is not an exhaustive list, and you can see SORMAS is one of those. The way that we look at investments is to look at a global goods maturity models to help prioritize where we want to invest. There's software maturity, sort of the technical completeness of the product, the global utility, as well as the community support. And each of these 3 major indicator areas has sub-indicators that describe specific aspects. So for example, within software maturity, you see the security, scalability, productization, documentation, and interoperability and data accessibility. We also, under global utility, want to ensure that there's strong country utilization. It fits within the digital health or e-health strategies and infrastructure within a country, that it is addressing specific digital health interventions as classified by the WHO, that the source code is freely available, and that there's a funding and a diverse funding revenue stream to ensure longer term sustainability. And finally, we want to ensure that there's a strong community behind these tools, that there's opportunities for community engagement and governance. There's a publicly available roadmap and user documentation and multilingual support. All of the things that can ensure that the global good can be used in multiple countries. Now, each of these indicators has a scoring from low, medium to high. It's a very lightweight maturity model to quickly assess where we want to make investments. And with SORMAS, the team has done an initial assessment and identified several areas that they wanted to improve the SORMAS software over the last 3 years or 3.5 years, and made a very systematic effort to increase their global good maturity model score to a full 30 out of a 30. And you can see a documentation of that in the above cited paper. And I think one of the reasons that we saw such quick uptake of SORMAS during the pandemic is that it really did focus a lot of effort on that maturity to make it easy to deploy and provide that global utility. Now, looking at interoperability and where it fits in, SORMAS is not a unique tool. There's multiple tools for supporting digital health in low and middle income countries. This is a map you can see of one tool called IRIS that does health workforce. It's in multiple countries. But within a country, here's a map of Uganda, you can see that there's a number of mHealth tools or digital tools that are already working. And so on the top left, you might have national scale systems, sort of monocultures of digital health tools, whereas on the bottom left, you have the 1,000 flowers that bloom and we want to support these as well. So how do we bring those together in a common framework, as well as to ensure that data collected in one system can be used in another? Is we look at something called OpenHIE. OpenHIE is a health information exchange, or open health information exchange, that includes it's an architecture in the community for defining common interactions of global goods that are used in low and middle income settings. In here, you see typical services for metadata in the middle, the registry services for terminologies, client registry or master patient index, facility registries to know where services are delivered, health worker registries, product registries. And then on the top, you see that the various business domains, such as shared health record, aggregate health management information systems, et cetera. And at the bottom, you see the various points of service systems that are at the health facility or at the health clinic that health workers, clinicians, providers are interacting with as they provide service. And the key to all of bringing these disparate systems together are the standards. Particularly, we're looking at HL7 Fire as an emergent standard that works well in the low and middle income country context with its bandwidth issues. Specifically for COVID-19, we've established a COVID-19 task force within OpenHIE that meets on a weekly basis. One of the main activities that we have right now is to take the WHO COVID-19 surveillance case report form and map that into a FHIR questionnaire, and using that FHIR questionnaire, map it against ICD-11 and link codings, as well as the related FHIR clinical resources such as observations, encounters, and diagnosis. The point of doing this is to provide a common, not just data dictionary, but a data transmission and mapping standard for case reports so that they can be used by SORMAS, by DHIS2, by systems at port of entry, by EMRs, all of the systems that are, which there are many that could potentially touch a person with COVID, and for which a case report form needs to be developed. And what we want to do is to bring those, during those trigger or sentinel events, is to initiate a case report, map it into FHIR, and put it into a case report repository or shared health record for various public health as well as clinical needs. And we can see SORMAS in the previous presentations has played a role both as in the clinical management of the cases as well as from a public health perspective. And this data workflow is not specific to COVID-19. The content is, but as we establish all of the standards for data exchange and sharing of metadata around the case report and repository, we can really bring all of these systems together so that with the next time that a pandemic occurs or a next large outbreak, we'll be much more prepared globally to deal with the response. Thank you very much. Over.
Wonderful. Thank you very much. To all the speakers, to all the presenters, I've just received instructions from the director, so to speak, to keep it short, to not extend too much. But I think we did very well. We had a very big portfolio. Some of the questions that were asked and put here in written, we have tried to address them also in writing. But I think we should still allow ourselves for some more questions and responses, because it's lunchtime after all, and we will not have the digital lunch. The digital lunch doesn't get cold, right? So we can still allow ourselves, I would think, for a few minutes for questions or comments from the audience to any of our speakers here. You must, if you want to ask a question, you either type it into your to the log, or you unmute your microphone. So while this is maybe still starting to come in, I would like to raise a question. We have seen very exciting developments being developed in different countries. So, for example, Fiji had established a special procedure in SORMAS for screening air passengers and cruise ship passengers many, many months before Europe did so. And did so as a procedure, and even long before it was even envisioned to do so in SORMAS. Ghana established this full integration with barcode-based digitalized integration of laboratory samples and laboratory results. Nigeria was on the front in including this response, SMS-based response of the lab samples, and also the contact tracing. In France, we have yet another approach of alleviating the burden from the local health departments with respect to the contact tracing and integrating that part from part of other contributors in the system. And it's also just a few examples. There are probably many more. I could also mention some from Switzerland that we don't have the colleagues from Switzerland here, unfortunately, who themselves have also developed new technologies and new approaches and procedures that we have built into the system. Now, one of the challenges for us, I can say openly, that we have been a bit overwhelmed by the need, by the response, by the demand, and our organization in managing this open source procedure and curating this open source activities and those offers were not up to the level that we would have needed to really accommodate all this positive energy. So we probably would have been able to produce even more, to put more rubber on the road if we had been better prepared in installing a professional, or let's say high capacity open source curation procedure. We are in the process to do so and to improve that, but we have been a bit overwhelmed, to be honest, and we would like to be better in that pace. And I would like to hear some comments and recommendations how we could do that. So I'm not sure whether maybe we have already been cut out, or maybe participants are not even able to hear us. I'm not so sure what the situation is. I see there are still participants in the room, but I don't know if they can hear or see us, or if they're even able to comment. There's one comment coming in. Okay. So
they are able to hear us and see us.
All right, at least that's something. Are there any questions from the audience, or recommendations or comments?
Well, I think if I get it right, they are not able to speak.
Yes.
So I think they can write.
So there's a question: is there an app for SORMAS? Well, SORMAS is a system, is an IT system, and yes, there's a mobile version of it which functions as a real app, and so that's what's being used, especially in Fiji, but also in Ghana and Nigeria, where mobile public health work is more important even than in Europe, and especially where the local offices do not have solid IT infrastructure available. So there, the mobile application is really the key for functionality, and it's the default operating mode actually. So yes, there is an app, but it's not an app that you can simply download on an app store, because for security reasons, this is a professional application that must be uploaded on a dedicated device that has to do with data security and data protection. So the actual SORMAS app is not something that you can download on a store, even though the whole system is open source. What you can download open source is the symptom diary that links and synchronizes into SORMAS, and that is available in iOS and in Android, but that is only for the contact person. So that will not allow you to see or to access data, but it will allow you to export data into the public health SORMAS system. There are more questions coming in. There's a question to Carl. Maybe Carl, you would like to answer that question. Is a working group of transforming WHO to electronic template that you mentioned open to the public? Can one be a partner? Carl, can you answer that?
Yes, it's open to the public. I'll put a link to the call logs. It meets Mondays at 11 a.m. US Eastern, and happy to have you participate. Thank you.
Okay, so I think I now need to stop the session and close the session. I would like to thank you all, the participants willing to participate here on a Sunday. Some of you from time zones that are middle of the night. Thank you especially to all the presenters, and also thank you and my compliments for all of you who have been able to advance and push SORMAS forward. As Chikwe has just mentioned, the director of NCDC, his quote is, "We keep pushing." So do we all, and let's keep pushing. We still have a lot to do in fighting against the pandemic, diminishing the burden of disease, keeping it as low as we ever can. And after the pandemic is before the pandemic. And second to that, there's also a lot of other diseases that we currently are losing out of track a bit, but they also cause a lot of burden of disease. And SORMAS, as other tools, help to control that. So even if we should manage to get over this pandemic soon, the added value of SORMAS will certainly last. So thank you very much for all of you to contribute to this very interesting presentation. I myself learned a lot of new information even for me, and looking forward to work with you furthermore, and also to contact some of the participants here who may have now gained interest to also engage in SORMAS, either as being a contributor or a user. Thank you very much to everyone.
Thank you.
Thank you.
Thank you.